Neurology Quiz number 88. Describe the clinical features, investigation and treatment of neuromuscular amyloidosis. Part 1 of 2, clinical features. In the systemic amyloidosis, there is extracellular deposition of insoluble amyloid fibrils in the body tissues, leading to progressive multi-organ dysfunction. Systemic amyloidosis is inherited or acquired. Inherited is of the following types. Hereditary transthyretin amyloidosis is the most common inherited systemic amyloidosis. Here, a mutation in the transthyretin gene on chromosome 18 results in amino acid substitution in the protein transthyretin, which carries thyroxine and retinol. This causes the protein to misfold and aggregate in body tissues. Rare hereditary types are apolipoprotein 1 and gelsoline-related amyloidosis. Acquired amyloidosis is of two types. The first is light chain or AL amyloidosis, which is a plasma cell disorder characterized by production of monoclonal light chains of kappa or lambda type that misfold and deposit as amyloid on any tissue other than the central nervous system. And the second acquired type is acquired wild type transthyretin amyloidosis, which is caused by age-related instability of transthyretin and causes amyloid deposition at a slow rate, which becomes symptomatic in old age. Neuromuscular complications of hereditary transthyretin amyloidosis. Neuropathy. This has been reported worldwide and can be severe and life-threatening. Most transthyretin mutations show mixed neurological and cardiac involvement. The most common TTR mutation worldwide is associated with an early onset phenotype in endemic areas such as Portugal and Brazil, and a late onset phenotype in non-endemic areas such as the United States. Patients with the early onset phenotype present with a small fiber neuropathy with autonomic dysfunction. Patients report burning pain and lancinating pain with paresthesias in the feet and allodynia. Autonomic features include erectile dysfunction, gastroparesis, diarrhea alternating with constipation, and orthostatic hypotension. Urinary retention and abnormalities of sweating and pupillary reaction may be seen. Symptoms progress to involve proximal legs, upper extremities, and ultimately the large fibers are also involved. Examination reveals decreased temperature and pinprick sensation in the distal extremities. In the later stages, impaired joint position sense and vibration sense, as well as weakness occurs that starts in the lower extremities. With progression, patients require support to walk and may become wheelchair bound. The disease course is less severe than the late onset type, with a mean survival of 12 years. The late onset type is often sporadic, has low penetrance, and is seen after age 50. It presents as a large fiber sensory motor neuropathy. Patients often have bilateral carpal tunnel syndrome, and autonomic involvement occurs late in the course. Progression is more rapid than the early onset type, and patients become wheelchair bound on an average within 6 years, and the mean survival is 7.5 years. In the United States, the most common transthyretin mutation usually presents as an isolated cardiomyopathy, almost exclusively in African Americans. Peripheral neuropathy can occur in 15 to 35% of these patients. Myopathy, muscle involvement is rare and usually occurs after onset of neuropathy. It presents with symmetric proximal muscle weakness in the extremities with elevated CPK. CNS, hATTR can also cause amyloid deposition in the eyes with vitreous opacities and in the brain and leptomeninges, causing cerebral hemorrhage, dementia, and stroke-like episodes. Rare types of hereditary amyloidosis. Apolipoprotein A1 related familial amyloid polyneuropathy. The Van Allen type is rare. It was first described in Iowa. It is due to mutations in the apolipoprotein A1 gene on chromosome 11. Apolipoprotein A1 is a major component of high-density lipoproteins, and the mutation impairs its degradation by proteases. Typically presents in the 4th or 5th decade, mainly affects the kidneys, liver, and gastrointestinal tract. Some patients can develop a length-dependent polyneuropathy, as in transthyretin amyloidosis. Gelsoline-related familial amyloid polyneuropathy is also uncommon. It is caused by mutations in the gelsolin gene on chromosome 9. It is endemic to Finland. Gelsolin is an actin-binding protein found in plasma and white cells. The gene mutation renders it resistant to breakdown by proteases. Symptoms can manifest in the third or fourth decade of life. Typically, there is a triad of features, which includes cranial and sensory neuropathy, corneal lattice dystrophy, and cutis laxa, which is an inelastic connective tissue that appears as loose skin and skin folds. The most commonly affected cranial nerves are the facial nerves. Neuromuscular complications of acquired amyloidosis. Light chain amyloidosis, or AL. This is the most common form. It is due to a plasma cell dyscrasia in which a B cell clone secretes light chains that misfold and accumulate in target organs as extracellular amyloid. Cardiac and renal dysfunction is the most prominent feature. Peripheral neuropathy at onset occurs in 15% of patients and in 30 to 40% as the disease progresses. It initially begins as a small fiber neuropathy and involves the large myelinated fibers only late in the disease. Patients with neuropathy have symmetric numbness, burning pain, and allodynia in the feet, which progresses in a length-dependent fashion. With involvement of the large fibers, there is impairment of vibration and joint position sense, as well as depressed deep tendon reflexes, and weakness occurs late in the course of the disease. Bilateral carpal tunnel syndrome can occur due to deposition of amyloid in the tissues. Muscles can be involved, leading to symmetrical proximal muscle weakness and mild elevation of CPK. Muscle biopsy shows amyloid deposition in the perimysium and endomysium and perivascular region. The other acquired type is the wild type transthyretin amyloidosis. In this type, non-mutated natural transthyretin dissociates into monomers which misfold and slowly aggregate into pathogenic fibrils which become symptomatic in the elderly. Deposits are most common in the heart, leading to cardiomyopathy. Carpal tunnel syndrome and lumbar canal stenosis can occur due to amyloid deposits in the carpal tunnel and ligamentum flavum. Peripheral neuropathy may occur but can be asymptomatic, and rarely myopathy may be seen. This slide lists the non-neurologic manifestations of amyloidosis in the eyes, mouth, skin, heart, kidneys, and GI tract. These slides show skin manifestations with periorbital purpura and ecchymosis over the jaw in amyloidosis. These slides show macroglossia and cutis laxa. This slide shows the common differential diagnosis for amyloidosis and differentiating features. Conditions include CIDP, idiopathic peripheral neuropathy, diabetic neuropathy, lumbar stenosis, and ALS. This list shows red flags in a patient with peripheral neuropathy that would suggest amyloidosis.